Thank you, everyone. Welcome to our last plenary session for our CME course. Really excited to be speaking to you today about honest aging. And I am not Dr. Leipzig. I am Dr. Helen Fernandez. Dr. Leipzig, unfortunately, could not join us today. So I will be presenting on her behalf, as well as some other details that I have added into the presentation that I think will really kind of have you think about being a better doctor, clinician, for your older and severely ill patients. Just to remind you, I'm Helen Fernandez. I am Gerald and May Ellen Ritter Professor and Vice Chair of Education at the Brookdale Department of Geriatrics and Palliative Care at the Icahn School of Medicine. And we'll get started. I have no disclosures. What I hope to cover with you is first to describe differences in the approaches to care for older adults and those with serious and chronic illness, introduce ways to improve prioritization of care for older and seriously ill, and formulate care plans for older and seriously ill adult patients based on their biological age as well as age-related changes, and then really bringing it all home. We've been talking about the 5 M's throughout these 4 days, and as well as concepts of palliative care. So what matters most: mentation, mobility, medications, and multi-complexity. So when we think about life expectancy, you heard a bit from Dr. Morrison at the beginning of our CME course on Tuesday. Older adults are living longer. So if you live up to the age of 65, what's your expected median age of survivability? 83.4. If you live to the age of 85, what is your life expectancy average? 91.3. And those are differences between males and females, with the females being on the higher numbers. If you live to 100, most likely life expectancy, median life expectancy would be 102.2. So definitely we are seeing this segment of the population, those over the age of 65, are now 1 out of 5 older adults, 20%, and the numbers over 85 and 100 are growing as well. So what would life be for those who are especially over the age of 85? Most of them would surprise you, actually report being in good or excellent health, 65%. How many are living with dementia? Almost a third, 28%. How many are having significant limitations in many geriatric syndromes like vision, hearing, mobility, communication, cognition, and self-care? About 40%. And how many are frail? And we'll dig more into frailty in a little bit, about a quarter. And how many are actually living alone? 23%, with more women living alone than men. And how many, and this is many times for people who think that most older adults live in nursing home, less than 10% actually live in a nursing home. So as we think about what's that feeling that older adults have of feeling like they're a burden to others, about 10% have that feeling. To sum it up, actually, most of us live into old age and will be in pretty good shape. And really thinking about what's that approach that we've been kind of really talking about these last 4 days. Really thinking about the 5 M's as a framework in terms of prevention, in terms of screening, and in terms of treatment, right? And this is the big M that really encapsulates care overall is multi-complexity, but we're thinking about mind, mobility, medication, and what matters most, right? So we've been hearing talks this week about depression and delirium and dementia. You've had workshops on functional assessments, mobility. We had a plenary around medication prescribing, thinking about the Beers criteria. And then what matters most, we had many conversations about that in terms of having these conversations and really getting to delivering that patient-centered care. So you can actually scan this QR code, go directly to those 5Ms, where you can dig in a little bit more deeply. But when I think about that geriatric lens, I think about a bit of what Dr. Meyer was just talking about, really a holistic approach, a whole person, not thinking about just the disease or the organ system. We want to enhance independence and quality of life. We're thinking about prevention as well. And when appropriate, we want to send patients to have early rehabilitation. We want to figure out what is important to them, what's important to their caregivers and their family. And we're not doing this alone, right? Many of you are interdisciplinary team members, social workers, physical therapists, nursing, chaplains, right? All of us are working together to deliver this care. It is not reliant on just one of us. So who will you be in old age? And so we're going to go through three possible scenarios on patients that are chronologically the same age of 85. So we have Rose, who you'll hear a little bit more about, Isaiah, and finally Nancy. And we'll talk about, right, the difference between chronological age and more the physiological age. So Rose is what matters to her is seeing her grandchildren grow up. She considers her health excellent, and she has a new diagnosis of hypertension, and she probably has a good chance of making it to 100. Really, she has no other chronic medical illnesses and then pretty independent in her ADLs and IADLs. How about Isaiah? Isaiah really, his focus and in terms of what matters most to him is creating sculptures. He has had diabetes for 40 years and now has low vision due to diabetes. He also has COPD, has new diagnosis of rheumatoid arthritis, has pain and joint swelling, and he's feeling like he's in pain, difficulty using his hands, depressed and scared. What matters to him is creating those sculptures, and that's becoming a little bit harder to do. Let's talk about Nancy. Nancy, what matters most to her is spending time with her friends and family. She has mild Alzheimer's dementia. She also has COPD. She lives alone. And her concerns is that she's had about 10-pound weight loss in the last 6 months. She's had more difficulty walking. She's fearful of falling and therefore doesn't get out as much because she's fearful she's going to go get into a bad fall. She's short of breath when walking, and unsure what medications she's taking. So in these three case scenarios, same chronological age, but definitely represent themselves physically and functionally and cognitively in different ways. So chronologically 85, but each and every one of them different, right? And so this is the heterogeneity of aging, right? Not all of us age in the same way, and each of these patients have a different path. And we think about what is their biological age, right? Not just their chronological age. So biological age is important. What's the current relationship between their current health state, right, and proximity to worsening health and death, right? And a lot of it is obviously surrounded in terms of how they're feeling and how they rate their own feelings of health, but also what we detect in terms of physical and cognitive dysfunction as well. Can be estimated by clinical features, which I'll talk a little bit more about frailty, and then biomarkers such as CRP, creatinine, systolic blood pressure, albumin, and these are all intermittent, right? They're markers. They're not. There's not one of these markers that's going to give you the diagnosis. It's really the compilation of all of this, the accumulation of all of this. Um, Weathering appears to accelerate the biological aging process, and that means having extraordinary stress throughout your lifetime also contributes to your aging. And so there's a growing disparity in physiological functioning due to this continual exposure to adverse conditions. And accumulating this over a lifetime really contributes to premature health deterioration. Life expectancy, we know, also is separated by identity, race, and ethnicity. As you can see in this graph, we can see that there are different age markers depending in terms of ethnicity, self-defined. And we can see where the life expectancy alters by this self-described ethnic race. So let's go back to our three patients and thinking about the heterogeneity of aging. Individuals of the same age differ in vulnerability to adverse health outcomes, and that's what biological age is. So if we were going to say Rose would be defined more as fit. And our last patient would be frail. Isaiah might be entering into frail, is pre-frail, and vulnerable. So let's talk about Rose first. So what does it mean to be fit? Well, to be fit would be to be independent, to be feeling as normal as possible, however that's defined for the patient, spry, but I just happen to have, some physical changes like gray hair. But otherwise, I'm able to do a lot of the things I've always been able to do. Maybe a little bit slower, but I'm pretty much doing a lot. So when we think about normal aging, you're going to have changes that are physiologically happening to you. You're going to walk more slowly. You're going to have a more of a stoop posture. You will definitely have flabbier arms and a pot belly. You will have moments where you might be a little bit forgetful, what we call the tip of the tongue phenomenon, where you just might forget a name and then you'll be able to recall it. You will definitely have more adverse reactions to medications. There's more susceptibility to those reactions. I think about, for example, in which we heard in the medication talks and about if you're on a beta blocker, for example, and your baroreceptors are decreasing as you age, your ability to have orthostatic hypotension is increased as you're aging. And so that might be more exacerbated on some of the antihypertensive medications. You're going to urinate more during the night, and you're going to have less reflexes in response. You're going to be less thirsty when you're dehydrated. So it might be very hard to pick up when you're feeling dehydrated. You can have we talk about atypical presentations in older adults. Well, that's the typical, right? So for example, 20% to 30% of MIs in older adults are not going to be presenting with chest pain. They may be presenting with change of mental status like delirium. So the atypical becomes more typical. And sex is often less spontaneous. So what's not normal is actually very common, right? And so what we find is like moving into this part of older age can be scarier. It'd be harder to talk about and not really a part of our culture. So how do we make it more of a part of a culture? Oops, sorry. I think my slides froze a little bit. Here we go. We think about what we think about What are those changes that happen that are more frequent? Not that everybody has them, but that are more frequent in older adults. Well, those are falls, for example, gait and balance issues. Not that every older adult has it, but they're more frequent. Issues around cognition, issues around weight loss and malnutrition, vision and hearing, and incontinence. Um, Mood disorders are more common. Energy level is decreased, arthritis and pain also, and sleep disturbances, and which I'll talk a little bit more about frailty. So these are, again, not that every older adult has each and every one of these, but definitely more common in our older adults. And this is beyond the physiological changes that happen. Um, these are changes that happen, maybe related to other diseases like for falls and gait. Maybe there are issues, cognitive issues. Let's say Parkinson's that's contributing to that, or orthostatic hypotension contributing to that. So you can imagine there's a lot of accumulation. We often don't screen for sleep disorders, and we've included in your slides just ways to screen about sleeping and seeing whether or not older adults are getting a good sleep. Um, what about frailty? What is it? We talk about it, but how do we define it? Well, frailty is a loss of physiological reserve needed to deal with stresses like illness and trauma. And this picture kind of demonstrates as we are younger, all the way to the right of this slide, we're able to take stresses and injury and overcome them. But as our physiological reserves with time decrease, if we have a stressor, that as we grow older may send us into having more adverse outcomes, like a hospitalization, and in some situations, death. So sometimes those are those insults that push us over the edge. We have a lot of physiological reserve at the beginning, and as we grow older, we have decreases of these reserves. And this is what we talk about when we're talking about frailty. So, frailty increases the risk of bad outcomes in falls, disability, comorbid disease states, delirium, cognitive decline, iatrogenic complications, social withdrawal, and death. It's going to complicate recovery post-op. It's going to increase complications. It's going to lead to loss of functional status. It's going to be harder to recover, a prolonged recovery, increased mortality as well, right? And it might be with frailty, you're at times you can have an increased length of stay because you're not going to be able to stabilize or get right back to your pre-hospitalization status when you were well. So it's a lot harder. Frailty improves predictive markers of many, many indices we use in anesthesia and cardiology, Eagles. When we incorporate a frailty index, it's in older adults, it's going to be a higher predictive value. So, what are some frailty measures? It's really an attempt to quantify these physiological compromises. And I'd like to talk to you, and I'll walk you through an example. We have the Freed, which is more of phenotypic frailty. We have the Rockland deficit accumulation and the Frail scale. There's no gold standard and there's no direct, so these are all indirect measures. The Freed is a biological syndrome and it's decreased reserve and resistance to stressors. The Rockwood is more accumulation of age-associated deficits, both medical, social, and functional, and it's a measure of vulnerability. So I'd like to share with you a little bit more specifically the Freed, which is the phenotypic frailty. So in in patients that are frail, they have a weight loss unintentional of 10 pounds or more over the past year. They have weakness, a grip strength that is lowest for their sex and BMI. They'll self-report feeling exhausted, having difficulty getting going, and this happens for more than 3 days out of the week. They're slower to walk. Their walking speed is at the lowest tercile at 20%. And they just in general have low activity. So these are all the components of phenotypic frailty. And then they're rated by in these 5 metrics of either being robust to being frail, which is a score of 5. So these are some examples. You'll see more and more in the electronic medical record that there are some tools that are indices of frailty, frailty, for example. And this is really taking into account what chronic medical illnesses an older adult has, from like hypertension, ischemic heart disease, atrial fibrillation, heart failure, history of having a CVA, chronic kidney disease, neurological deficits, diabetes, peripheral vascular disease, arthritis. And then it also takes into account not only those medical illnesses, but also the presence of any geriatric syndrome, weight loss, anorexia, visual impairment, hearing, polypharmacy, falls, dizziness, and urinary incontinence, memory, fragility fractures, sleep disorders, history of falls or any mobility issues, foot disorders. And then it also not only, so you have the medical, the geriatric syndromes, but you also have the social deficits. Are the patient mostly homebound? Is activity limited? Is there social vulnerability? And do they require care? And so this has been incorporated, and there's a couple of trials that have looked at this, incorporating it within electronic medical record. This one, for example, is in the EPIC frail scale screen. And then it's checked off of whether having the issue, like in the past 4 weeks, have you felt tired all or most of the time? And they're dichotomous of either being yes and no. They look at activity level, they look at the presence of chronic medical illness, and then in terms of weight loss. And here, the lower the score, right, is the more robust, and the higher the score, 3 or more, is defining frailty. So really finding ways to kind of picking up these patients earlier, being alerted that these patients are going to be more predisposed to adverse outcomes, right? And just a reminder, right, that when I talked about what is life living over the age of 85, what are things that are more common, frailty is around, in this population, around 25%. Despite all of this, there's a lot of upsides in aging. So I don't want to paint a picture, because not all older adults are going through all elements of frailty. For older adults, when we've surveyed them, they feel less insecure. They say and do what they want. They're more likely to see the big picture. They understand that time is limited. So there's a greater focus on being present and what matters and what's really important. There's more emotional control, and there's less negative emotions. It just happens less frequently. There's increased wisdom, and there's, a lot more coping mechanisms and problem solving strategies as we've aged, because we've seen it, right? So what can we do as clinicians, doctors, to help patients and their loved ones keep their eye on the prize, regardless of the biological age? Well, it's really getting to living the most enjoyable and engaged and meaningful old age. It's really kind of talking about what Dr. Meyer talked about in terms of loneliness. It's screening for it. It's finding ways to celebrate older adults, and intervening earlier, right? So thinking about less about the cycle of frailty and how can we turn this into an opportunity, and really intervening on many of these chronic illnesses and inactivity and undernutrition, right? So encouraging these positive perspectives of aging is really important. And one of the things is really thinking about how to adapt to the new normal. Um, and For example, Grandma Moses didn't start painting until she was 76. So picking up a new hobby is a good idea. Um, why did she wait so long? Well, she was embroidering, but then her arthritis made it too hard to hold. So she really used another method of creativity, where she didn't have to use a lot of her hands for little activity, and could really transition to another creative activity. And she painted every day for 25 years. So we want to help reframe independence for our patients, um, and not just characterize patients as being dependent or independent, right? There's interdependency, not needing to do everything independently, cooperating with others so that you're able to do what's the most important. So if you need help to get somewhere, finding that way to get somewhere, would be great, right? And so not just seeing it as a deficit. One of the other things that I think is really, really important is the frame that as a health system, both inpatient and outpatient, that we have to take. And that's that perspective of really having age-friendly health systems. And really the 5Ms really incorporate this. And this is a premise that older adults have unique needs. This age-friendly health system, and we heard a bit about it from Dr. Sannon as she talked about hospitalized older adults. This is supported and created by John A. Hartford, the IHI, the American Heart Association, and the Catholic Health Association of the United States. And this is to prevent and improve health outcomes and lower costs in older adults. And so it's a new way to organize care for older adults. It's implemented in all settings, not just in the hospital, at home, in the community. And it's taking into account and meeting the triple aim of IHI of improving individual health experience, improving population health, and reducing care cost. We want to promote aging-friendly healthcare, and taking that frame of those 5Ms, what matters, meditation, mobility, mentation, and multi-complexity. So I wanted to give you some examples. There's a great resource. You can go on IHI to hear more about age-friendly health systems. Your organization can actually go be recognized for doing a lot of these measures. And it's really about assessing and documenting a lot of those 4Ms, and placing it within your chart, making sure you're screening for depression, making sure you're screening for falls, reviewing medications, and that's level 1. And then encouraging you to go to level 2, where it's showing outcomes and going through the last 3 months of how many people you've actually screened for this level. And they're going to get into higher levels, level 3. And so this is great resources. They have tools, they have screening tools that are free. They're evidence-based. There is, if you go on the website, they really find some strategies, how to integrate this into your electronic medical record, and how you can get accreditation to be recognized for level 1 and level 2. There's a whole booklet, outlet, and guide of how to do this in the outpatient setting as well. It really concentrates around, again, what matters most, screening for depression and delirium and dementia, but also thinking about aligning care plans with what matters most, looking at medication use and high risk medication use and how to avoid it, and then helping develop care plans that address these issues. So I really want you to think about this as a really useful frame as we're thinking about care for older adults. We hope these last four, and those with serious chronic illness as well, we hope that this last 4 days have given you some tools to really, really address these issues. And I think the place to start with your patients is what matters most. That really is a great place to start. What do they want to do that's meaningful in their life? And you want to frame your care plans around that. So, what are tips that I want to offer on being a better doctor for your older patients? Resist ageism in yourself, your colleagues, and staff. Think about kind of words that you're using and how to define older adults. Older adults are better than, and they've done actually surveys around this, and older adults is a better terminology than seniors or elderly. Prescribed, as Dr. Meyer said, socialization and engagement. Help your patient right size their expectations. Regularly consider deprescribing or decreasing dosages, or really does that patient need to be on that medication? Do they have the indication? And reviewing those medications. My 6-month rule is someone refusing a suggestion may be open to it at another time. So maybe thinking of taking a break about a recommendation and then bringing it up again. Teach your patients to be advocates for themselves. Encourage them to let others to advocate for them as well. And laugh more, you and your patients. Be a doctor who cares for the difference, and any clinician, not just doctors, between caring for 80-year-olds and caring for 60-year-olds. So I hope I've taken you through a journey of really thinking about why is care different in older adults? How do you prioritize that care? And how do you use the frame of the 5Ms to help you think about how to screen for many common geriatric syndromes and how to develop a patient-centered plan for your patients, and remind you about the resources that are out there through IHI, age-friendly health systems, both inpatient and outpatient. They're free, they're downloadable, and they can really help as resources for improving care for those who are older and seriously ill. And with that, you know, I want to pose this question to you. Who are you in old age? Some of us, and this is a great picture of how this older adult, viewed himself in terms of old age. And, as Gertrude Stein said, you're always the same age you are inside. And Dr. Leipzig has written about this book, An Honest Aging, An Insider's Guide. It's a really helpful guide to use for your patients as a resource. There are many guides out there in terms of helping your older adult patients reframe aging and think about kind of the questions to ask when they're thinking about asking you questions about whether they should be on a certain medication or not anymore. And I thank you very much for your attention. My talk has ended, and I know that some people ask me many times when I talk about reframing aging, they're like, how do we really talk about reframing, not aging just with our patients, but in society. And I think that's another place where we can work on, right? thinking about the heterogeneity of aging and appreciating not just only the super ager. It's really realizing that some adults are maybe more vulnerable and frail, and figuring out really that messaging that it's not about them, it's about us, right? We're all getting to that age, hopefully, and we need to reframe that conversation that it's not about us, it's not about them, but it's about us and a society that's going to take care of older adults and see that as a priority as well. Well, I hope you've had a great 4 days. A reminder that the videos, the plenaries are all available till October 19th in the video library. All the plenaries have been videotaped. You can download the presentations. We really appreciated having you as participants in our course. Don't forget to fill out your evaluations and apply for CME credits and MOC credits if appropriate for you. We really hope you take many of the tools that you have heard about and the evidence that you've heard about and suggestions around communication, around screening, and are able to incorporate it into your clinical care. And thank you very much for your attention. And we hope to see you again next year for our 25th anniversary. Thank you and have a great day.